अस्सलाम वालेकुम। अस्सलाम वालेकुम बच्चों। How are you? I hope you are all fine with the grace of God and your families are also fine. And I hope we all deliver lecture in the lecture hall and you all attend to classes personally. Now, today we will discuss postpartum hemorrhage. So, what do you understand by postpartum hemorrhage? As the word signifies, post after partum delivery hemorrhage. So, delivery after, hemorrhage after delivery. Now, what is the learning objective of today's lecture? It is to describe the significance of hemorrhage, discuss the process, and discuss the prevention of postpartum hemorrhage, to describe the management of postpartum hemorrhage, and briefly describe the uterine inversion. Postpartum hemorrhage remains a major cause of maternal mortality and morbidity. Approximately half of women die annually, and in developing countries, this incidence is very women that are delivering dies midwives and without proper antenatal care and precautions during the delivery. Now, how we can define postpartum hemorrhage? It is loss of 500 cc or more during vaginal. So, loss of blood. If it is more than 500 after vaginal delivery, or more than 1000 cc during cesarean section, or blood loss, which significantly affects, or it is significant enough to cause hemodynamic instability. So, Pph or postpartum hemorrhage is loss of blood more than 500 cc after vaginal delivery, 1000 cc during cesarean section, or blood loss which significantly causes hemodynamic instability. So there are two types of Pph, primary or secondary. Primary occurs in first 24 hours of delivery, and secondary after 24 hours till 12 weeks after delivery or during the pregnancy. So primary and secondary, there are different types. Again, this is primary Pph. First 24 hours and secondary Pph after 24 hours. The incidence in the developing world, several countries in the world, it's an excess of 1,000 women per 100,000 pregnancies, and WHO statistics suggest 5% of women Pph account for more than 100,000 people. So it's a very high ratio. So how we can estimate? So we know patient has cc. As you can see, if there is only soiling of the centimeter of the pad, then it is 30 cc. If it is saturated small swab, which is the measurement of 10 into 10 centimeter, then it is 60 ml. If saturated sanitary wall of the pad is saturated, then it is 100 cc. And if incontinence pad, there is incontinence, it is 250. And if saturated swab, then it is 340 ml. the swab 45 to 45 centimeters. So it is saturated and it is 358 cc. If there is spillage of blood on the floor with this saturated swab, it's 110 from kidney tray, that is 100 cc. If you got laying on the bed, that is 1000 ml, and it is spilling of the bed and so this is how you will estimate losses. What can cause Pph? The most commonest cause is uterine pain. The uterus does not contract because its stomach does not contract and it becomes a flabby and feels water and blood starts collecting inside the uterine cavity. Trauma, it may be genital trauma, it may be trauma, it may be trauma. Full bladder also causes delay in uterine retain conception if there are pieces of placenta or membranes inside the uterine cavity. It will also lead to postpartum hemorrhage. Uterine rupture, uterine inversion, this uterine inversion is when the whole of the body of the uterus it comes out of the cervix and vagina when after delivery of the placenta. So this is uterine inversion. It will also lead to primary postpartum hemorrhage or coagulopathy if there is blood flow. It is also the cause of hemorrhage. Secondly, Pph, the most common cause is uterine infection, uterus infection. So, secondary hemorrhage is cesarean section. So these are the causes of secondary hemorrhage. Now, what are the risk factors which can so we have to identify these risk factors during antenatal period pregnancy. To identify these risk factors, if the patient has these risk factors, then we should be prepared for the Pph. Prolonged third stage of labor, multiple deliveries, multiple pregnancy, episiotomy if she had episiotomy, fetal anosmia if she has delivered an large baby, because mammals are very linked to uterine. History postpartum hemorrhage, if she had previous history of Pph, then she will have Pph. Grand multiparity, if she's grand multiparity, para, placenta breathing, placenta abruption, pregnancy test hypertension, and infection. These were the risk factors for Pph. So, patient will present. She will have a massive blood loss. She will, if there is too much clots, she will be dizzy, she will have lightheadedness, fatiguability, decreased blood pressure, increased heart rate, tachycardia, hypotension, swelling, and tissues of the vagina. There are few things which is the mnemonic for movement regarding the etiology or the causes. These are 4 Ds. So whenever you are asked for the causes of Pph, you have to mention this mnemonic 4 Ds. Trauma, tissue, and trauma.
ये माइक थोड़ा सा पास कर दो माइक थोड़ा सा पास कर दो
That is uterine consists of about 70% of cases. Trauma, lacerations, hematoma, inversion, rupture. It accounts for about 20%. Tissue, retained tissue. It maybe a placental piece, it may be a piece of membrane, or invasive placenta. If the placenta is inherited, so it accounts for about 10% of the pph. Thrombin is coagulopathy. If the patient has coagulopathies, she may have pph, so it is only 1%. Again, this is 40s causes. Thrombin may be in the preeclampsia, preeclampsia, placenta eruption, pyrexia during labor, bleeding disorders, hemophilia, anticoagulation, or disease. Tissue, if he has retained tissue, retained placenta, placenta urethra, tone, uterine atony may be due to placenta previa, distension of uterus like pregnancy, polyhydramnios, uterine relaxants, inflammation, just use relaxants. नहीं आ रही शुरू से नहीं आ रही
मैम अभी होना
हेलो अब आ रही पता नहीं हेलो हेलो ठीक sorry for the interruption. Now we were discussing 4Ts. So tone, hypotonia may be due to placenta previa, overdistension of the uterus, multiple pregnancy, polyhydramnios, macrosomia, uterine relaxants, like halothane if it is given during general anesthesia, previous pph. Trauma includes episiotomy, macrosomia, a difficult delivery. She may have low genital tract tears, cesarean section, and other causes include Asian ethnicity, if she is anemic, if there is induction of labor, if she is obese, BMI is more than 35, or if the patient has prolonged labor, or age she is grande. So this is the pie chart showing 4Ts. So the tone, it is 70%, trauma is 20%, tissue is 10%, and thrombin coagulopathy is only 1%. So this is the picture showing uterine atony, as you can see over here. This is the uterus. There is bleeding from the maternal sinuses, open maternal sinuses. This causes bleeding, and this bleeding collects inside the uterus and it causes uterine atony. So this is uterine atony. So atony of the uterus causes we have already discussed. Now tissue, retained placenta products. It is a cause for massive transfusion. If there is retained POCs, the patient will bleed. So what are the risk factors for tissue? If she is having placenta previa, if the placenta accreta and greta pergreta, that is invasive placenta, she had previous cesarean section, she had previous curettage, or she has an infection. So all these factors will lead to increased retained placental products. How we can prevent PPH? There should be certain measures which can be done during pregnancy. Antenatal period, we should improve the maternal health. If she is anemic, correct the anemia prior to delivery. So identify high-risk patients who may develop PPH. We have discussed the risk factors. So take history, detailed history from the patient, and identify the high-risk patients. We should be having blood grouping. So in case of emergency, we should know which blood to be transfused. During delivery, she should have a normal duration of labor, because prolonged labor will lead to Pph. So slow delivery of the baby, expert obstetric anesthetist is needed, spontaneous separation and delivery of the placenta during cesarean section. And during delivery, active management of the third stage of labor. After delivery, the placenta should be examined, whether it is complete or not, induced or accelerated labor by oxytocin. So if she is having slow progress of labor, it should be accelerated by, augmented by oxytocin. Exploration of uterovaginal canal after delivery and delivery of the placenta. We must inspect the genital tract for any tears or lacerations. To observe the patient for about 2 to 4 hours after delivery. So after delivery, we must observe the patient for Pph. Now, what is active management of third stage of labor? It is recommended by WHO that active management of third stage of labor, it should be done in all cases because it minimizes the blood loss. It minimizes the blood loss, cut short the third stage of labor. So uterotonic immediately after the delivery of the baby in all births. Which uterotonic is used? That is syntocinon. 10 units of oxytocin is given. IM or IV, it is recommended. Other option is misoprostol, but we are using in active management is oxytocin, 10 units of oxytocin. Ensure a continuous supply of high quality oxytocin by maintaining the cool chain. Delayed cord clamping. The cord should be clamped about at least 1 to 3 minutes to reduce the rate of infant anemia. So it is delayed for a period of 1 to 3 minutes. The only indication for early cord clamping in modern day obstetrics is asphyxiated baby who needs immediate neonatal resuscitation. So there should be delayed cord clamping for about 1 to 3 minutes. Perform controlled cord traction. So deliver placenta by controlled cord traction. In settings where skilled birth attendants are available, controlled cord traction is recommended for vaginal births. It is recommended method for removal of the placenta in cesarean section also. Postpartum vigilance for uterine tone. Postpartum vigilance for uterine tone. Immediately assess the uterine tone to ensure a contracted uterus. Continue to check every 15 minutes for 2 hours. If there's uterine atonia, perform fundal massage and monitor more frequently. But sustained uterine massage is not recommended as an intervention to prevent Pph in women who have received prophylactic oxytocin. Now, how we will manage a patient with Pph? First of all, communication among the staff members. Then resuscitation of the patient. We have to do immediate emergency measures to resuscitate the patient. Monitoring and investigations. Monitor the patient and send baseline investigations. And arrest the bleeding. Try to find out the cause and arrest the bleeding. So this is a flow chart for the principles of management of the Pph. First of all, arrest the bleeding, replace the circulatory volume, and reverse the coagulopathy. So first of all, call for help, announce code blue, resuscitation, ABC, and uterine massage. Start massaging the uterus to increase the tone. Then medical interventions, uterotonics. Uterotonics are given. 10 units oxytocin stat, IV or IM is given, or we will discuss in detail, or we are giving argometrine, carboprost, or misoprostol. If the patient does not respond, at the same time we are giving fluid resuscitation, crystalloids or colloids, and blood products. So always give blood for blood. If blood is not available, then we will start with the crystalloids or colloid infusion and if the respective blood group blood is not available, then we can give O negative blood to the patient. So if the patient does not respond to the uterotonics, then we will go for surgical interventions. We'll shift the patient to theater. We will do uterine balloon tamponade or uterine compression sutures, uterine artery ligation, internal ligation, or interventional radiology, or peripartum hysterectomy. If there is coagulopathy, the signs of TIC, then we have to give packed RBCs, FFPs, platelets, cryoprecipitate, factor 7A, tranexamic acid, and salvage. So these are the management flow chart for the management. Now the treatment of Pph follows the mnemonic hemostasis. Hemo for medical management and stasis for surgical management. So hemostasis. H, help, ask for help. All your seniors. Involve everybody. Assess, A for assess, vital signs, the amount of blood loss, and resuscitate the patient. E, etiology. Etiology, to try to find out the cause and ensure the availability of blood. M is for massage the uterus. Start rubbing the uterus so that it contracts. O for oxytocin, so give uterotonics. Oxytocin, that is oxytocin, it is given IV stat or in the form of infusion. Then stasis for surgery. S, shift to OT. T for trauma, exclude trauma or tamponade. So T is for trauma and tamponade. If there is trauma, try to repair it and do tamponade, uterine tamponade. A is apply compression sutures. S to stepwise pelvic devascularization. I for intervention radiology, and S for subtotal hysterectomy. So help. H, ask for help. Whenever there is Pph, the first thing to do is to call for help. Call anesthetist, consultant on call, hematologist, alert blood bank, alert one member of the team to record the events, fluid, drugs, and vital signs. Assess the blood, vital signs, blood loss, and resuscitate. So monitor vitals, pulse, BP, temperature, respiration, oxygen saturation, put the patient on cardiac monitor. So this is the initial management. Call for help, assess airway, breathing, circulation, ABC, provide supplementary oxygen, monitor vital signs, start fluid replacement with IV crystalloid, obtain an intravenous line. So pass 2 wide bore cannulas of 18 gauge to secure IV line. Catheterize the bladder and monitor urine output, assess the need for blood transfusion, and send labs, which is full blood count, coagulation, screen, and blood grouping, cross-matching. Now, after resuscitate, make two, as I've already told you, 2 wide bore cannulas, 18 gauge, IV fluids, crystalloids, and lactate or colloids should be given, moist oxygen, 10 to 15 liters per minute, and catheterize to monitor the urinary output. Etiology, E for etiology, establish the etiology, assess the uterine tone, whether the uterus is contracted or not, local examination to exclude the trauma, examination of the placenta and membranes to exclude retained bits, any retained products of conception. Investigations should be blood grouping, cross-matching, CBC, coagulation profile, electrolytes. So ensure availability of blood, immediately send blood for grouping, cross-matching, and arrange for at least 4 units of whole blood. Active treatment of the postpartum hemorrhage. Massage the uterus to stimulate contraction, administer argometrine 0.2 milligram intramuscularly or centometrine intramuscularly. Empty the urine bladder by catheterization. A second dose of centometrine can be repeated in 10 minutes if bleeding is not controlled. So if the uterus is atonic, do uterine massage. If the uterus is soft, boggy, massage is performed by placing one hand in the vagina and pushing against the body of the uterus while the other hand compresses the fundus from above through the abdominal wall. The posterior aspect of the uterus is massaged with the abdominal hand and the anterior aspect with the vaginal hand. So this is uterine massage. Oxytocin, start oxytocin infusion 40 units in 500 ml normal saline at 15 to 30 drops. Methergine or ergometrin is given 0.2 milligram IV. So these are the oxytocics which are given oxytocin infusion. It is contraindicated if the patient has heart failure. Ergometrin or methergine 0.2 milligram may be given IV, repeat after 15 minutes, maximum 4 doses. It should be avoided if patient is hypertensive. Carboprost, prostaglandin F2 alpha, these are the injections which are given intramyometrial. 0.25 microgram is given, repeated after 15 minutes, and maximum 8 doses can be given. It is not given in patients with asthma. Misoprostol, which is prostaglandin E1, it should be given in the dose of 200 micrograms sublingually or parectally. Usually, dose is 600 micrograms. So, single tablet is 200 microgram, and it is given in a dose of 600 microgram. Tranexamic acid, this is in the form of injection, IV injection, 500 to 1 gram can be repeated after 4 hours. So these are the oxytocics which should be given. We have already discussed this. Prostaglandins include carboprost and misoprostol. Now S shift to OT. While shifting the patient, the following things may be done by manual compression of the uterus. This is how by manual compression of the uterus is done. One hand is over the fundus. You grab the uterus over here, and your second hand is inside the vagina into the anterior fornix. So you will compress the uterus in between these two hands. So when you will compress, what will happen? It will close the maternal sinuses and it will arrest the bleeding. So this is bimanual compression with two hands. T for trauma or tamponade. If any trauma, you will immediately repair it. And then for tamponade, we have certain balloons or catheters or packing with the gauze. So tamponade effect is what? You will insert a balloon inside the uterus and inflate it. So what will happen? This balloon pressure will be more than the pressure of the maternal sinuses, the bleeding. The pressure with which the bleeding is coming, it will be overcome by the intrauterine pressure with the balloon. So it will have a tamponade effect and it will close the maternal sinuses and will arrest the bleeding. So there are certain things which are used for tamponade effect, that is Beckley balloon, taken Blackmore tube. There is another Rush balloon, and Foley's catheter may be used, or uterus can be packed with gauze. So this is Beckley balloon, which is inserted inside the uterine cavity and then inflated with normal saline. 500 cc normal saline is inserted. This is taken Blackmore tube, which inserted and then inflated with normal saline. This is another balloon, Foley's catheter. This is Foley's catheter, inserted inside the uterine cavity and then inflated with distilled water. And this is Rush balloon catheter. So these are used to acquire the tamponade effect, uterine tamponade effect. And this is, if no balloons or Foley's is available, then we can use gauze. Gauze pieces can be inserted, this wire gauze. This uterine cavity is packed with this, like this. The whole of the uterus is packed, and one end is left into the vagina. So this is uterine packing. Now compression sutures. These are P-Lynch, modified P-Lynch, and this is CHO sutures. So this is brace suture or the P-Lynch suture. These are the compression sutures which are applied on the uterine surface so as to compress. We will apply this stitch like this, and then we will squeeze the uterus and tie the stitch. So uterus will be squeezed. This is another stitch which is applied like this. Hello. So this is another form of suture which is applied on the uterus. Now stepwise pelvic devascularization. What is pelvic devascularization? We will, first of all, we will ligate the uterine artery. Bilateral uterine arteries, they are ligated. Then internal iliac artery, ligation. So we will tie the internal iliac arteries so as to treat this to arrest the bleeding. This is the uterus and this is the internal iliac artery. So internal iliac artery is ligated over here and the uterine artery is ligated over here. So this is how we will ligate. We will do stepwise devascularization. Or ovarian. Ovarian artery is also ligated. So uterine artery, internal iliac and ovarian. These are the steps of pelvic devascularization. This is internal iliac ligation. We will ligate the internal iliac. The intervention radiology. This is selective uterine artery or internal iliac artery embolization with the help of angiographically guided techniques. So what happens? This is uterine artery embolization. Actually, we insert a femoral catheter by femoral vein through this femoral artery. So through this catheter, we will inject polyvinyl gel particles. They will go to the uterine artery and block. So it will uterus and ultimately it will arrest the bleeding. So this is uterine artery embolization. This is how the uterine artery is embolized. This is uterine artery and these polyvinyl particles, they will obstruct the uterine artery. Subtotal hysterectomy. This is the last resort. If all the measures fail, you have given uterotonics, you have done bimanual uterine compression, you have done with the tamponade effect and devascularization, stepwise devascularization. Even then the uterus is, there is bleeding from the uterus, then we will go for subtotal hysterectomy and you will call your second consultant and you will do subtotal hysterectomy. Ovaries must be preserved at any cost. Now, if there is coagulation disorder, 4T, that is thrombin, which is about 1%, it is a rare cause of postpartum hemorrhage, unlikely to respond to the measures described above. If she has coagulation failure, then she will not respond. The patient will not respond to all those steps which we have done till now. So most coagulopathies are identified before delivery, allowing for advanced planning, preventing postpartum hemorrhage. Now, if she has coagulation failure, coagulopathy, then DIC regimen may be needed in massive hemorrhage. We need FFPs, we need blistering concentrates, we need cryoprecipitates, and factor 7. So FFPs for every 4 units of every 4 units of packed cells. So after every 4 units of packed cells, we will transfuse 4 units of FFPs. Or if PT or APTT is more than 1.5 times the normal. Or if the platelets are less than 50 into 10 power 9 per liter. And cryoprecipitates are needed if fibrinogen is less than 1 gram per liter. Now, what is the role of recombinant factor 7A? It is used in hemophilia. It reduces the bleeding in Pph. So it should be used in consultation with a hematologist in life-threatening Pph. Trauma. So if trauma is the cause of Pph, what kind of trauma? It may be lacerations, it may be tears. So starting from the outside, vulva, vagina. Any lacerations or tears should be looked for. Then inside, cervix, cervical tear, Then up we go into the uterus. There may be rupture of the uterus or hematoma. Hematoma is also a trauma. Hematoma formation. It may be a paravaginal hematoma. It may be a broken ligament hematoma. So hematoma, they need observation if they are less than 5 centimeters. But 5 centimeter or more, these hematomas, they should be drained. Uterine rupture, if the patient has rupture of the uterus, then we have to repair the uterus or either do hysterectomy. Uterine inversion. So what is uterine inversion? As you can see over here, this is cervix and this is the body of the uterus. So, and this is vagina. The whole of the body of the uterus has come out of the cervix into the vagina and outside the vagina. So this is uterine inversion. So what you do, we will manually replace the uterus inside the vagina. So this is how, with the help of a hand and fingers, we will reduce the uterus inside the vagina. So when whole of the uterus is inside, then we will make a fist and start uterotonics so as to contract the uterus, and then we will remove our hand. So this is how we will manage uterine inversion. Now what is the flow chart? This is the flow chart of management of major Pph. So major obstetric hemorrhage, when the blood loss is more than 2 liters. If she is losing more than 2 liters, when it will be 2 liters? When she soaks her clothing, she soaks her bed, and the blood drips over to the floor. Then this is massive obstetric hemorrhage. So continue major obstetric hemorrhage protocol. Call for help. Senior midwife, obstetrician, anesthetist, hematologist, alert blood bank, lab, and alert consultant obstetrician on call. Resuscitation, ABC, oxygen by mask, fluid balance, give crystalloids or colloids, blood transfusion, blood products, and keep the patient warm. Monitoring and investigations. So what we will do, we will pass 2 IV lines, 18 gauge cannulas, send blood for CPC, coagulation profile, your renal function test, LFTs, and grouping and cross matching. So these are the investigations which should be sent. Pass Foley's catheter, attach the cardiac monitor to the patient, hemoglobin bedside testing, blood products should be given. Consider central and arterial lines, commence the record chart. Weigh all swabs and estimate the blood loss. Start the medical treatment. These were the initial management. Now start the medical treatment. Bimanual, after bimanual uterine compression, empty the bladder, oxytocin, 10 units, IV, ergometrine, then oxytocin infusion, 40 units in 500 ml normal saline, carboprost, 0.25 microgram, IM every 15 minutes, up to 8 doses, carboprost, intramyometrial injections of prostaglandin F2 alpha, 0.5 milligram in both corners of the uterus, misoprostol. It can be given parenterally, about 800 to 1000 micrograms. Now, shift the patient to the theater. Is the uterus contracted? Examine under anesthesia. Has any clotting abnormality been corrected? So, you will shift the patient and you will look for, you will examine the patient under anesthesia, and if there is any clotting abnormality, you will correct it. Inside the theater, you will remove the POCs if there are any, pass intrauterine balloon catheters, or apply brace sutures, compression sutures. If it all fails, you can consider for intervention radiology, that is uterine artery embolization. If all fails, then the last resort is hysterectomy along with the second consultant. So after hysterectomy or after doing all these measures, you will shift the patient to ICU or high dependency unit. Documentation and counseling. Clear documentation of the sequence of events and cause of bleeding. It's mandatory. Debrief staff, family members, and patient. And risk reporting. So these are the last steps in the management of Pph. Now, what is the golden hour? The first hour of the Pph is taken as the golden hour. If management is started within first hour of onset of the Pph, then the patient has the best chance of survival. Chances of survival decreases sharply after the first hour. So what are the complications? Complications of the postpartum hemorrhage. These are anemia, anterior pituitary ischemia leading to Sheehan syndrome. There will be secondary amenorrhea. There will be uh, absence of lactation. So this is due to the postpartum pituitary necrosis. There will be multiple blood transfusions. So she may be having transfusion reactions, late or delayed. Death, patient may die. Dilution coagulopathy, myocardial ischemia, orthostatic hypotension, and postpartum depression. So these are the complications of postpartum hemorrhage. Now, what are the key points or take-home message? Do not delay fluid resuscitation and blood transfusion. As soon as the patient comes to you, you will resuscitate with fluids and blood. Be protective. Young patients, they compensate well. Minimal signs appear at 1 liter of blood loss. So they can tolerate up to 1 liter. Hypertension appears very late if blood loss is more than 200 cc. So consider blood products administration before coagulopathy develops. So give blood for blood before there is TSC. Consider early hysterectomy if medical and surgical interventions they are ineffective. So do not prolong the mystery. Do hysterectomy if your medical and surgical interventions they are not fruitful. In patients with placenta accreta, obtain advance high-risk consent to cover the possible interventions because you are foreseeing that she may have Pph. So take a consent for hysterectomy before high-risk consent. She may need multiple transfusions. She may need a hysterectomy. So you should take a high-risk consent in advance. Thank you. So if you have any questions, you can ask. Or no questions? Okay, thank you.